Today, we are fortunate enough to have as our guest Dr. Stefanie Green. Some of you who've been with us have seen Dr. Green before. We've had her on a few programs. She's a wonderful guest, wonderful speaker, informative, entertaining, and incredibly knowledgeable. And she's going to tell us about progress in our northern neighbor in terms of right to die options. At the end of this presentation by her, you will probably have the same feeling I had every time I actually listened to her, which is enthusiastic about the progress they're making in Canada, depressed about how badly we're doing down here. But having said that, hopefully you'll learn some important information. One thing just about our format, today's format's a bit different. We typically have a presentation followed by some questions, but this time we're going to have an interview. Our founder, Faye Girsh, is going to be doing an interview with Stefanie and trying to ask her all the kinds of questions she thinks you would like to ask Stefanie yourself. Okay, without further ado, let me pass the program on to Faye, and Faye can tell us about a little bit more about Dr. Green and then begin her interview. Faye, it's all.
Thanks, Barry.
Sure.
Very welcome to all of you. Nice to see you. Did you ever have a neighbor that you were so envious of you could hardly stand it, who seemed to accomplish so much more than you have in the same amount of time, who got their needs met so much faster than you did, who you would like to be like, but you're not? So I have such a neighbor. It's called Canada. And I am so jealous of the laws that they've had and the progress they've made. But I'm not jealous of our speaker. I am so admiring of her. I'm so happy to introduce you to her so you can be jealous too of what goes on in her country. We have as our guest again, Dr. Stefanie Green. You were here, I think, Stefanie, about 2 or 3 years ago.
Yes.
And two major things have changed. One, the law has changed rather drastically. And two, you've written this wonderful book called This is Assisted Dying.
Exactly.
So that will be on sale March 29th on Amazon, and I recommend that you all get it. I would like Stefanie to autograph it for you, but that doesn't seem possible at this point. You probably wouldn't believe that Stefanie Green is a young woman who's had 10 years of general medicine experience in her practice, and then 10 years more as maternity and child care, delivering babies for 10 years. And then in 2016, when the law changed, Stefanie became a provider for medical aid in dying, assessor and provider. And I'm so proud that she was one of the first in Canada to do that. And this book recounts her first year practicing as a MAID practitioner. And it's very interesting because it talks about the effect on her. She's a very good storyteller, so it talks about many of her patients and the changes in the law and how that happens. So now we'll get actually to the book. By the way, where are you right now, Stefanie?
Thanks, Faye. That's such kind words. I am in Victoria, BC, which is where I make my home. So Victoria, British Columbia is on Vancouver Island, just north of Seattle, actually. Beautiful. Very close to Seattle.
Yeah. And you have a family?
I have a family. I am empty nested. So I have 2 children who are both away and just finishing university, and my husband and I still maintain the nest in case they rebound.
So how did you get into this? Why would you be one of the first people in Canada to leave a very nice obstetric practice and start helping people die?
Yeah, it's not a simple question to answer. I think the best thing I can tell you is that as a person, I've always been interested in the intersection between medicine and ethics and law. I've always just found that interesting. And when I found myself in medical school, I found myself drawn to certain different areas of medicine, I think because of that. And I wasn't really sure what I wanted to do. And in fact, when I chose to do family medicine, when I was done, I chose to do extra training, some fellowships. And I actually did a partial fellowship in infant and maternal care, which I really thought I wanted to pursue. And also in palliative care, because I was really drawn much to my surprise, by end of life care. And I did both and didn't feel like I could really plunge 150% into each one. So I pursued maternity care, which was a real passion of mine. And I did that, as you mentioned, for about 22 years. But as a Canadian, watching the stories in the news unfolding and different court cases, I always followed along the end of life issue. And when I saw the Carter case happening and the decisions made by our high court that were going to ultimately be changing our laws, I was really drawn into what was happening around me. I was quite happily surprised, and just following along now as a physician with 20 years experience, it had a whole new appeal to me in different ways. I was a little bit tired with my maternity work, doing 24-hour call in hospital and trying to recover from that physically was becoming harder, in truth. And my husband was encouraging me to pull back a little bit so I could be home more before the children actually left the nest. So there was a lot of competing factors. And I really wondered who would do this work. Once it became legal, who would actually step into that world and do that work? And there were so few people. I really felt like I wanted to give it, to look into it more and try. And I was just drawn in further and further.
But you don't just learn that. How did you learn most of what you know now? Well, most of your job, I think. But
yeah, no, it's true. In medicine, we have an expression which many of you will have heard, which is see one, do one, teach one. And that's really true as you learn to do different procedures in medicine. This was not going to be something I could see one, do one, teach one. So I actually was a little bit proactive. I went with some colleagues to Amsterdam in 2016. By coincidence, the World Federation of Right to Die Societies has every 2 years has an international conference. And there was one scheduled in Amsterdam in May of 2016, which was 1 month before our law was scheduled to change. So I found out about that, and I went there with two colleagues, expecting to see lots of Canadians, and there were very, very few. But through that conference and through an extra experience I had in The Hague with the clinic, the end of life clinic there, I was exposed to people who had been doing this work already for 10 or 15 years. I met researchers, I met advocates, I met lawyers who'd argued cases. I was exposed to people from the US and from all over the world, and I really learned about everything from data and research and drug regimens and practical work. So it really. I was quite impressed actually with the conference and the quality of the work that I was hearing about. And that really was the basis of my education. After that, it was a big blind step into just doing and then learning as I went, to be honest.
You also developed a group, a sort of support group there from Amsterdam that you kept.
Yeah, I'm extremely proud of that. So in Amsterdam, there were very, very few of us. And we quickly realized that the conference was so rich, we couldn't go to every event we wanted to. So we literally divided up who would go where and shared our notes. And when we came back to Canada, we maintained that little email group as we started taking our first steps. And it was invaluable to have a colleague who was also doing their first events and trying to deal with funeral homes and find IV tubing and which pharmacy would you go to. So we really learned a lot from each other and realized we weren't the only people in the country doing this. So we reached out to colleagues and very quickly grew to a group of maybe 20, maybe 30 by the end of a couple months from all across the country. And very soon after, within about 4 or 5 months, we realized we needed a national association that would represent the people that do this work. There was no one else that could advocate for us or what our needs were. We all came from such diverse backgrounds. And so I helped co-found the Canadian Association of MAID Assessors and Providers, CAMAP. And that organization has grown tremendously in the past 5 years. And it's one of the very proudest accomplishments of my life, to be honest. We've grown into a nationally recognized group of experts in assisted dying in our country and are now, having produced guidelines and teaching modules and training. And I think other countries and models are looking to us now for guidance. So it's been tremendous.
It's so important to have a network like that. We have something like that, ACA MAID in the United States.
Exactly. Excellent group. Same idea. Yeah. Lonnie Shavelson and those guys. Yeah. Really, really good.
So you talked about your first, the first patient you talked about was a guy dressed in a clown suit.
True. He wasn't my first patient, but it's the first story I tell in the book, for sure. Right. I think to capture the essence of what it is that I do. Yes. Ed was
that would
unforgettable.
Make one think that you and he both had a wonderful sense of humor. and that you could get down to him on a personal level and make him happy. And even though he died alone, you were there and you had a good laugh together as he was taking his last breath. I thought that was charming.
Absolutely. And I think that story, Ed and his story really just epitomizes how everyone is unique. Everyone has something that's important to them that I shouldn't presume to understand. It's part of my job to speak to people to find out what brings meaning and joy to them and for me to facilitate that, whatever it is, even if it means being dressed as a clown, whatever it takes. It's everyone's individual. Every case is individual. We need to recognize that uniqueness in everyone. Yeah.
And tell the joke that you told him on his.
I'm gonna make them buy the book.
Okay. Yes, it's in the book. So when you started out in 2016, the law was quite different.
Yeah.
Without confusing everybody, because it's really confusing.
Yeah.
Can you start by saying what the law was then, and then what the
We'll
law
get to
is
what it
now,
is
and
now.
we'll go into all the details of the law because it is quite intricate, I think, by this time.
Yeah, I think I can keep it fairly simple. So let me know if I'm not. And I would argue that the law is very, very similar still, although there are big implications of difference. And I think it's important to say that because people will often, who are opposed to assisted dying, will say, oh, there's a slippery slope, or your law has changed. And actually, our law has barely changed, and there is no slippery slope. But I can get into some of that. So I think what's important before I list that, the most important thing, which many of your attendees today will know, is that the law in Canada, first of all, which is national, it covers every square inch of our country, which is large. It came about not because the voters demanded it, and not because the government said it would be a good idea, but it came because of people and patients who challenged the fact that there used to be a blanket prohibition of assisted dying in Canada. So you just couldn't do it. It was illegal. And the Carter case, it happened, and the decision came in 2015, said that universal prohibition was against our Charter of Rights and Freedoms, basically a constitutional issue where that there were, in fact, situations where it might be okay, and it was unconstitutional to ban it generally. So that's important, because then once that was true, the government had the choice to either just leave it be and let it be the Wild West, or to make a law regulating the practice. And that's what they did. They made a law, and they simply said there's 5 things that need to be true. The patient needed to be an adult over 18. They needed to be eligible for Canadian health care, which means you can't just come up to Canada and ask for it. The patient needed to ask voluntarily. They couldn't be coerced into this decision. They needed to have the capacity and understanding to make this request and give consent for it. And they needed to have what was called a grievous and irremediable condition. Now, those 5 criteria are all still true. The only thing that's changed is the definition of a grievous and irremediable condition. So originally, the law said 4 things needed to be true. In order to say that you have a grievous and irremediable condition, you needed to have what the law called a serious illness, disease, or disability. So something had to be wrong with you, and it had to be serious. It needs to make you not function well. So the wording in the law says that you need to be in an advanced state of decline of capability, meaning you're no longer functioning the way that you used to because of your serious illness. And that it needs to be causing suffering that you believe is intolerable and unrelievable by any means acceptable to you. That's all still true today. The only thing that's different is that the original law also required some element of linking your eligibility to your end of life. As you know, in the United States, in anywhere that this is legal, you need to have a terminal illness, defined in the US as 6 months or less. That was never the intention of our high court decision. It explicitly did not link it to an end of life regime, but the government added a criteria saying that your death needed to be reasonably foreseeable without defining what that meant, which was difficult for many years. But it was specifically not meaning a terminal illness with 6 months prognosis, not even 1 month, not even 1 year. It was a vague notion to allow some clinical flexibility. We knew when that law came out that would also contravene the constitutional decision of the court, but the government let it stand until someone challenged it, which they did in 2019, and the courts threw it out, saying it was unconstitutional. So it's no longer a criteria in Canada. There is no link to end of life specifically in our law anymore as of March 2021.
Just
I
to
hope that was clear.
reiterate what you said, Stephanie.
Yeah.
So our law in the United States, now in 10 states and the District of Columbia, well, not including Montana, I guess, says that two doctors have to agree that you have 6 months or less to live. That's the
Exactly.
criteria. Nothing to do with suffering or anything like that. It's 6 months or less to live. It's very simple compared to your law, but it's also extremely restrictive.
Exactly.
Almost irrelevant.
And so as I like
to do with the end of life.
Yeah, which is why I like to point out that the Canadian system is rigorous, with a rigorous procedure and a rigorous eligibility criteria, but not related necessarily to end of life. And so that's a significant difference.
And do you want to talk about how it's changed now and the tracks? That's very complicated.
So with the original restriction to some form of relationship to end of life, we were allowed to, people who were accessing MAID were primarily people with end of life issues. So people with terminal cancer, neurologic conditions, or conditions that were close enough that we could see that trajectory towards their end of their life, end stage Parkinson's, end stage lung disease, end stage heart disease. So we were busy helping those kinds of patients. Once they removed the criteria that you needed to be, near end of life in some way, it opened up the possibility that people who are not near end of life in any way could now access MAID in Canada. And that meant that people who suffer from things like chronic pain might step forward, or people who suffer from mental health diagnoses, but nothing else physical might be able to step forward. I would point out that and this is important, that in Canada, prior to the change in law, there was no restriction or exclusion for mental health patients. We see many patients that have comorbid issues. They might have someone with a long-standing depression, but they also have pancreatic cancer. Those people have access to MAID and always have and always will, I expect. But when mental health is the only reason you're applying for MAID, originally you could apply and have access, but if your death was not reasonably foreseeable, you wouldn't qualify. So essentially they were excluded, though not explicitly in the law. Now that we've removed that criteria, it opens the door for those with the mental health disorder to access MAID without that restriction. So they're able to. So because of that, the government got a little scared and didn't know what to do about that. And so they put into the law a temporary exclusion. Starting in March 2021, when our law changed and became a little bit more accessible, closer to the original decision, the government said, if a mental health disorder is your sole underlying condition, you may not access MAID until March of 2023, by which time we hope to have figured out what to do about this and how to assess these patients and what kind of safeguards we might need. But that will automatically come out of the law, automatically, unless the federal government changes our criminal code. So we have that pending right now. And in the meantime, we have now two tracks to access MAID. One is, unfortunately, with the terminology, if your death is still reasonably foreseeable, which you don't need to be qualified, if it is, then you have a series of what we call safeguards that need to be met. Things like you need to make a written request, it needs to be witnessed, you need to have two clinicians involved. So a series of safeguards that are quite straightforward if you're on a trajectory towards death. But if you're not on a trajectory towards death, if you are that patient that has maybe 20 or 30 years of chronic pain, or you've got chronic fatigue syndrome and you want to access MAID, you have a longer list, a track 2, where you have a much longer list of procedural safeguards that need to be met. And in brief, they have to be all the same ones from track 1, but they also mean that you need to be made aware of all the reasonable and available means to reduce your suffering. You need to be offered consultations to those resources, and the patient needs to give serious consideration to those resources. And somebody with expertise in the issue that's causing that suffering needs to be involved in the assessment. So if all of that can be accomplished, then that patient has access to MAID. So a much higher bar of safeguards kind of around that track of people who are not on a trajectory towards death. I hope that makes sense.
Besides my envy of everything you've just said,
yeah.
My understanding is that if you ask for help in dying and you're no longer capable of receiving it when it's time, you can still get it. Now, could you please explain that? Because that is the dilemma that makes us all crazy here in the United States.
Yeah, it's driving a lot of people crazy, in fact. So yes, so now that I've explained there's two tracks, one is a more straightforward track if your life is nearing end, and the other is a less straightforward track but still available. We call them track 1 and track 2. If you are on track 1, so not available to track 2 patients, not available if your life is not on a trajectory towards its end, but if you have what we call a death that is reasonably foreseeable, we have created an exception where because the law requires you to give consent at the moment of the death, unless, here's a very specific exception, and it's called a waiver of final consent. So waiving the requirement of final consent. I want to point out before I describe how that works, this is not the same as an advanced request for MAID, where you say, oh, I've been diagnosed with Alzheimer's. If A, B, and C are true, I would like to have an assisted death. That is called an advanced request. That is not yet legal in Canada. That's what most people want, but we don't have that. What we do have, however, that if you are on that track 1, if your death is reasonably foreseeable, whatever that means, let's say you are a patient with metastatic breast cancer and you've applied for MAID.
Let's talk about dementia.
Let's talk about dementia. Well, I'm going to get to that. Okay. Let me give you the easy example first. Because this change, this waiver of final consent was kind of invented for a woman named Audrey Parker who didn't have this opportunity. And she was 57 years old, 57-year-old woman with metastatic breast cancer. She said, my gosh, I'm going to die soon. I'd like to have medical assistance in dying. She applied for MAID. She was assessed for MAID by 2 clinicians. She met all the eligibility criteria and was approved and was setting her date to die. So she's been through the entire system. And she set her date. She wanted it to be in January because she loved Christmas and wanted to live through one more Christmas. So this was the summertime. And she said, oh, I'm going to make it to January, but one more Christmas. I'd like it to be the first week in January. And then in that fall, they told her, your metastatic disease has progressed to your brain. We're not sure you're going to be able to give consent in January. You might want to consider your options, which are to proceed now. Or if you don't proceed now, you might lose the option to proceed later because you can't give consent. And she said, well, that's not fair. I've been through the whole circus. I've given all these permissions. I've been found eligible already. She called herself assessed and approved. She said, I'm assessed and approved. I shouldn't be able to give you my consent now for January, even if I become, unable to do so. And the law, of course, didn't allow for that. So our new law now says if you're on track 1, and you've already been assessed and approved for MAID, you may enter a written agreement with your provider saying, I want it for January 4th at 3 p.m. If I become gaga and unable to give you consent on January 4th, you're still able to go ahead and provide me an assisted death. And that's not criminal anymore. So that's a waiver of final consent for a very specific patient population, which is not the same as an advanced request. Does that make sense?
Does it, everybody?
Thumbs up.
It does permit somebody with early dementia to say, I want to end my life at a certain date, even though I'm demented at that date, I can still get aid in dying.
So yes, so dementia. So again, to preface how we can use a waiver in dementia, the first thing to know is that with the original law and with the current law, patients with dementia can access MAID even without a waiver. There are ways that patients with dementia can already qualify for assisted dying in Canada. They do, however, have to give consent and be capable of doing so. So they need to make that decision before they lose their capacity. We can talk more about exactly how that works if you want, but essentially, as they're getting further and further into the disease, and they're nearing a time when they're probably going to be losing that capacity to make their own healthcare decisions, they're kind of getting to that place where they're probably going to cross that line. We call it midnight. Instead of turning into a pumpkin at midnight, they've lost capacity to make their own healthcare decisions. At 10 minutes to midnight, when they're very close to it, they could actually meet our criteria. They could be an adult with Canadian healthcare, making a voluntary request, with a serious illness that causes suffering, and that they still have that capacity. They haven't lost it yet. So we are able to do that. What the waiver of final consent does, it allows that patient a choice. Instead of saying, I'm ready to go now while I still can, I know that I'm still capable, I could potentially live for another 10 years, but I don't want to, it allows them to say, I know I'm nearing that time where I'm going to lose the opportunity to make this choice. I'm going to sign a waiver of consent. I'm going to set that date a year out, and I'm going to live every darn minute while I still have capacity. And then when I become confused and I'm unable to do that, I've got a date set where I know you're going to help, and we're still allowed to do that. So it gives them an option, which is a very powerful tool for patients with dementia.
Yay.
Yay.
We'll talk about voluntary requests, later.
Sure.
And this may have gone too fast for a lot of people, but I got so many things that I want to talk to you about. The second thing, of which I am insanely jealous, is a patient has a choice in Canada of drinking this stuff or getting a lethal injection from somebody like you.
Yes.
And what do most people do?
Yeah, this is a kooky thing in your country. So we do offer both options, which is based on the Dutch model and the Belgian model. And so we have had over 20,000 assisted deaths in our country recorded, up to the end of 2020, I think. So definitely much, much more. And although we offer both options in most places, 99.999% of them have been clinician administered. So I'm aware of, and I'm tapped into most clinicians in most places in our country. I'm aware of less than 20 self-administered assisted deaths. And I think, to be fair, there are some regions that don't offer it because they couldn't get the medication, or the practitioners don't want to, or it's not covered by our government. There's a bit of patchwork, but generally speaking, it is available across most of the country at a really reasonable rate, and the government does cover it, but no one's choosing it because, given the option, they like the idea of a controlled event with a physician in charge that they know will take about 10 minutes, and it's 100% effective. The oral option, while good, has about a 3% failure rate using the secobarbital that we use. Some people do regurgitate, and it does take longer. It'll take anywhere from 30 to 60 minutes, often less, but we don't have a ton of data yet. And so it's less sure. And a patient does need to be able to kind of sit up and hold the glass and drink it on their own, and be willing to have and have a digestive system that's functioning. And many people at end of life don't have all those things available to them.
It tastes terrible.
Plus it tastes terrible. They have to chase their favorite shot. So many people don't want to kind of take that risk. I've only done one oral death, and it was really, really important to my patient to not have an IV. In his mind, it had a correlation with a lethal injection and criminal events, and he felt incredibly strongly he didn't want that. But I've never had anybody else ask for it, and I've done well over 300 of these. So I think it's going to continue to be mostly this way in Canada.
I'm going to just divert into something less serious and less envious of. You call it MAID.
We do.
That name means medical aid in dying. It doesn't mean you get a maid to clean your house.
That's right.
But it is quite equivalent to voluntary euthanasia, in which you have a paragraph in your book about why that's not a good term.
Yes. Yeah, I think terminology is important. I think words are really important. There's connotations that are obvious and not so obvious, conscious and not so conscious. In the past, there has been a real effort to delineate, the nuances about what's done and who's doing it and who's giving consent. And I think in today's world, it's used primarily by opponents of assisted dying to conjure up past atrocities. I think we know that in Europe today, the favored term for assisted dying is euthanasia. That is the term used in Belgium, and it is the term used in the Netherlands, and it includes both the clinician administered or the oral drink. They call it
always
all
administered
euthanasia.
by the word voluntary. I mean, always.
Yes, always. Yes.
Voluntary. Yes.
Yeah. And so the difference between voluntary and involuntary euthanasia, of course, is voluntary euthanasia of a consenting, capable adult who says, "Could you please do this for me?" That's voluntary euthanasia, to relieve suffering. And then, I guess, in theory, involuntary euthanasia would be a clinician walking around with a syringe and giving it to people who didn't ask for it. The concept that that's even a possibility or something that could exist is quite offensive. And the term euthanasia, certainly in North America, conjures up, Nazi atrocities. And so usually that term is used by opponents of assisted dying. We made a conscious decision in Canada to use the term, we actually call it medical assistance in dying, or medical aid in dying. It's not very different. There's a nuance in it. And we did it on purpose so that it could be an umbrella term that involves both clinician administered or self-administered assisted dying, and that it didn't conjure up that more negative history, which I think doesn't apply.
It's interesting that in Australia they call it VAD, voluntary assisted dying, and in Switzerland they call it assisted suicide. Anyway.
Yeah, it's it's all over the place.
Yeah. And I also want to just go back a little bit to what you said about the World Federation of Right to Die Societies. It is my favorite organization. I was president of it for a while, and I've gone, I think, to every meeting for the last 200 years, whatever. And well, it started in 1980, so probably not. The next meeting, though, you should know, Stefanie, you do know, I'm sure, is where?
Is in Toronto, Canada, and Dying with Dignity Canada will be hosting that event in November of 2022. We're quite excited for them.
Yeah. I would not have picked that season of the year, but I am looking forward.
I might agree with you.
Toronto. Yeah. Anyway, I think you should know about that World Federation of Right to Die Societies, and people can become supporters. Only groups can become members, but it's still very worthwhile going, as Stefanie found out. And that year, of course, I was there. I didn't see you.
Yeah, no, I didn't find you that year.
Named after Marilyn Seguin, a Canadian woman who was a great pioneer in aid in dying.
Dying, yes.
To get back to the topic here, you mentioned when you go to visit somebody, you bring a box of syringes. Can you explain what that is all about?
Yeah, so when I go to provide the actual MAID event, the scheduled event, I have worked with and I'm planning to administer the medication. I go actually with 2 boxes, to be honest. We always bring a backup set of medication with us in case. We always have contingency planning. I'm batting 100 so far. I'm not planning to ever fail my patient, and we always come with 2 complete sets. But I work with a pharmacist who actually draws up the medications for me, divides them into syringes, labels them, sets them out for me. So when I get there, I have a series of 4 medications. I don't know if you want me to go through what that protocol is, but
I think people would like to know.
Yeah, so we have a protocol that's based on the Dutch protocol. There's lots of data from 20 years about its effectiveness. We found it very, very useful to have that. And it is essentially the same across Canada, although there are small differences. The first medication I administer is an anti-anxiety medication. It's midazolam, and we give it in a high enough dose that I would say 99% of the patients that I give it to fall into a very light and comfortable sleep with the midazolam. Very relaxed, very comfortable, and often symptom-free from whatever they were suffering from. So essentially, they're out and unconscious from that point on, unless they're used to be, except for the very, very few who are running on low oxygen because of their illness, and they tend to stay a little bit awake. The second medication I use is it's an extra one. Not everyone uses, but I always use it. It's a local anesthetic that we use just to put into the vein and let it sit there for 30 seconds to numb the vein, so we don't irritate the arm in any way. Now, it's true most of my patients are sleeping already, so it probably doesn't matter, but I'm not aware of what they're feeling or still sensing. So I always use the lidocaine to make sure I'm not irritating them in any way, because the last thing I want is for this to be distressing in any way. The whole idea is I'm trying to deliver a comfortable end of life. The third medication is, of course, the stronger medication, the one that's really going to be the final effect. We use propofol in Canada for a coma-inducing agent, just like what we would use in an operating room, but a massive, massive dose. And as we give that over a course of a couple minutes, the patient goes from that light sleep that they're in down into a more deep, kind of surgical sleep, and then a deep unconscious state, and then a deep coma. Essentially, their breathing stops at that point, and patients die at that point. But we never count on that happening, even though we know that it does. The fourth medication is given. It's a paralytic, and it makes sure that there's no muscular movement in the body. I mean, to be perfectly frank, we don't actually stop the heart. We stop respiration because hypoxia, and the heart stops beating secondary to hypoxia. We don't use, potassium chloride or anything like that for a number of reasons. We find that if we're in the vein, we use this protocol, we are 100% effective in about averages 8 to 10 minutes in British Columbia. So we find it quite good.
Are most of these done at home or in the hospital? Where are they done?
Yeah, so national data would have them pretty much even. They used to be a little bit more in hospital until COVID, and then of course that switched. But in the province that I work in British Columbia and Manitoba, there's 2 or 3 provinces where even from the beginning, the majority of events were in people's homes. That's still the case in British Columbia, where the vast majority are still in people's homes, which I think allows that flexibility in terms of time and access. Also, moving people to the hospital at end of life just for this event is very disruptive. It can be quite uncomfortable. So I never encourage that. But if they want that, we can do that. I've done some in hotels. We've started seeing funeral homes starting to offer rooms to gather in, to have a maid event there, and then have an event afterwards. I know one person who's done it in a camper van. I know people who've done it outside, national park, beachfront. I like to say anywhere that's safe and legal. But primarily this is happening in people's homes and in hospitals. Yeah.
So Dr. Green, the first one is from a physician here who asks, you mentioned Sicanol as the preferred drug for oral MAID. Is it available in Canada now?
It is. So when we first started in 2016, it was not available. We were aware of the history of the problems in the States, the price jump. Embarrassed to say there was a Canadian company that bought it and hiked that price. We actually fought as CAMAP, as the Canadian Association of MAID Assessors and Providers. We actually got together with a legal scholar and advocated for access to Sicanol, and which we now have. So basically what we have is we have a pharmaceutical company that will import the powdered form, and they will send it to any compounding pharmacy in the country for a very reasonable rate, who then, when a prescription is made, they will then compound it up into the liquid form and make the very clean barbiturate drink for us. So the quick answer is yes, it is available. It's available across the country. And my understanding is in British Columbia, if we do that, it costs about $700. $650, I think.
Who pays that?
The government of Canada pays that. The entire process, the clinician's time, the medications involved, the nurses, all of that is covered. It's a covered medical service in Canada, like all of our healthcare.
The patient pays nothing.
Zero.
This is
having said that, there are small exceptions. So in Ontario, for example, everything is covered, but they actually don't cover the oral medication, which is one of the reasons it hardly ever happens in Ontario. That's going to change very soon. So essentially, it's covered everywhere, and it will be covered everywhere. Yes, zero.
There was a question from Pamela about the use of the word euthanasia, wondering when it's used in the Netherlands, whether it's translated into their language or spoken in English.
It's actually in their own language, euthanasie or whatever it is in Dutch. I don't know how to say it. It is the term that's used in all their documents, in their law, in their guidelines. It is absolutely their preferred term.
Literally translated good death.
Yes, from the Greek.
And here's the big question. How can we best influence the culture to be pro-right to die? The US seems to be rampant with suicide prevention, and it's very frustrating to see.
Pro-life stuff.
Yeah, I think first thing is to differentiate suicide from assisted dying, which I think should not be confounded. And that's a whole lecture unto itself. But I think I once heard Dr. Timothy Quill speak. He's a palliative care doctor many of you are probably familiar with. And he really summed it up in one sentence, just beautifully. I'm going to keep quoting this man because I think it was brilliant. And he said, suicide implies some form of self-destruction. He said, assisted dying implies some form of self-preservation. And I thought that really sums up the essence of the difference. You can get into a big ethical debate, but the number one is to differentiate. This is not the same as an impulsive, irrational, suicidal attempt. This is not that at all. And so it's important to be able to address that when talking about it. Number two, I think that there is, you can't convince people to think a certain way. I mean, I don't mean to confuse subjects, but we see some of the changes happening in the US right now in terms of other rights, women's rights in particular, and they're unbelievable to those of us outside your country. So I don't know that you're going to convince anyone. I think that what you can do is look to other jurisdictions that are using models that are successful, that are working, that are showing there is no slippery slope, that are gathering data, showing the safety of what we're doing. And I think Australia is gathering data, Canada's and now got 5 years of data. There's good data from the Netherlands and Belgium. I think you need to be evidence-based. I think you need to make this not just he said, she said, this is what I think. I think you need to dig in and say, this is how it works. This is what's happening. This is what we've seen. This is what's working. This is maybe not working as well, but look at this. And I think you can hold up those models as examples. And I think the easiest issue to point to is clinician administered. I mean, I know that there's a bit of a move in California to look towards that, and maybe a few other states. But the laws that are working in California are still quite restrictive in terms of patients with have certain diagnoses. And, if they can't drink, if they can't, use their digestive system, you've got people being discriminated against because of their diagnosis. If you've got a colon cancer, can't use a digestive system, you just can't have assisted dying because it needs to be ingested according to the law. That's where you need to say that you're discriminated against people based on something that's unconstitutional. That's just, against people who are disabled.
There's a case like that going on now with Lonnie and Catherine Tucker. Yeah.
It's good. Yeah.
I didn't mention this before, but you have a graph in your book that shows 7,595 MAID deaths in Canada in 2020.
Yes.
Compared with 1,118 just 4 years before. So that it's gone up almost sevenfold in 4 years.
Yeah.
And during this period, there were 458 deaths in California. California and Canada both have 4 million people. They both passed their laws in 2016.
Yeah.
That's where we are, and that's where you are.
Yeah, it's a crazy difference. I would ascribe that difference to a couple things. Number one is your law is obviously restricted to those who are terminally ill. So right away, you've cut out a chunk of people because we didn't use reasonably foreseeable as 6 months. So much more open to a larger population. Also, the self-administered requirement is massively different. And that chunks out another huge number of patients who would maybe otherwise have access to the care. So I think that those two things alone probably account for the greatest difference. In Canada, some people will say, look, it's going up so quickly. What's happening? You guys are rampantly out there. But this is a new service. A lot of people still don't know that it's legal. It's 5 years later. I live in a MAID bubble. I think everybody knows about MAID and all about it. But the truth is, if I walk outside and ask the next 100 people that walk by my front door about assisted dying, a good chunk of them are going to say, oh, yeah, that thing I read about, I don't know what that is. So I think, when you have a new service in town, so to speak, there's a certain education level, information, it has to disseminate into the population. And once people understand it's available and start to access it and becomes word of mouth, you are going to see a natural increase over time in the first few years. Having said that, the numbers you're quoting, the national average in Canada, it's only 2.5% of all deaths. It's still a very, very small amount. 97.5% of people that died in Canada that year did not have an assisted death. This is just over half of what's happening in the Netherlands and Belgium. So it's not at all surprising that 5 years in, we're doing about 2.5%, whereas in Netherlands and Belgium, it's about 4.5, depending which year you're talking about. So I think we're right where we expect to be.
Let's talk about where you live, though.
Where I live is a special little place. So British Columbia is more than double the national average. So in British Columbia, over 4% of the deaths are by assisted dying. And I live on Vancouver Island, which is one region within British Columbia. And we actually have, the data from last year, from 2021, which I have access to, 7.4% of all deaths on the island were attributed to assisted dying. So this is actually the highest number in not just our province or our country, but in the world. And I think there's a number of reasons why that's true. I'm not so surprised. We have the best weather in Canada. We are a retirement community. Our demographics are skew older. So of course we are the population that might access MAID. People come here on purpose from Western Canada to retire. These are people who have made enough money to say, I'm going to go there and I'm going to pick up my family. I'm going to move. These are independent, opinionated, stubborn, mostly successful people who want to say in their death. So they're more likely to ask for MAID as they get older. This is a place where the healthcare authority, of all the things they do wrong, one of the things they did well is they saw this law changing. They saw the changes coming and they didn't wait for the law to change in order to prepare. They spent a year in preparation, figuring out how this might work, making up paperwork, getting people in place so that on June in June of 2016, we were ready to start. We didn't start the process in June 2016. We were ready to start the care in 2016. And three of my colleagues and I mean, we went to the Netherlands and we're ready to start doing this care. In a city where I live in Victoria of 300,000 people, to have 3 clinicians ready to do this work is higher than anywhere else in our country. So all of those things put together, made us kind of out the gate fast. I don't think the rest of the country will ever come up to 7.4%. I do expect the Canadian average to rise to the European levels. I do think after another 5 years, we might well be at 4% in Canada. But I think Vancouver Island will stay a unique little place probably for some time.
Can you ever imagine 50% of people who die prefer assisted dying?
That sounds like a big number. I can't imagine that, but we haven't seen it plateau yet. It has not yet plateaued. I expect it'll plateau probably at 10% or maybe a little bit under. It's hard to know. I don't know that 50% will be there, but we'll see. It's early days still.
Polling data from the Hemlock Society doesn't count, I think. But what about hospice and palliative care? You seem to have some difficulty with that.
Yeah, so in general, I think you won't be surprised to know that the palliative care community was reluctant to discuss MAID, was reluctant to provide any care that might facilitate that. There was a certain edge to the community in general, suggesting that they're very worried about their own reputation, and understandably. I mean, I have to say palliative care is a new specialty. They fought very hard for the past 20, 30, 40 years to clarify to patients and the public that they don't cause death, that going into palliative care doesn't mean, oh my gosh, you're about to die. They fight to explain that they are holistic care about comfort and quality of life, and they're very sensitive about that. Having said that, so they didn't want to wade into this. So there are many palliative care docs in Canada that just say, I don't provide assisted dying. I will never do that. Having said that, they're also the most patient-centered physicians I've ever met. And palliative care is essential for our patients because most of them need it and are already receiving it. And I have seen a huge change in the palliative care community where people kind of watched carefully, saw what we did, didn't necessarily obstruct, but didn't necessarily help. And now there are more and more palliative care doctors getting involved in this work, being more open to this work. CAMAP, the Canadian Association of MAID Assessors and Providers, we have a significant number of our membership are actually palliative care docs as well. I've seen a big shift, certainly not enough, certainly not like we're all going to sit back and say, well, that's not an issue. I mean, the majority still are very hesitant, and some are outright obstructive. But
Stefanie,
my job is to bridge that community.
If I remember correctly, Quebec was the first province to start MAID practices. And also, I had heard, and I don't know if this is true, the most likely province where people can go from hospice to MAID without any hassle. Do you know anything about that? And why, in a province that's 83% Catholic, should this be?
That's a great question. So Quebec has, as a province, Quebec has been far ahead of the rest of Canada, like for a long time. And the interesting thing about that, just politically, Quebec has always been quite distinct in Canada. Obviously, there's a language issue. They are primarily Francophone, and they've always kind of dwelled in their distinctness and kind of wanted to be distinct. I'm sure many of you are aware Quebec has tried to separate from Canada several times, never really happened. But in Canada, our criminal code that controls medical assistance in dying is it's a national legislation. It's our criminal code of the country. But healthcare in Canada is actually shared between the federal government and the provincial government. So healthcare is actually administered provincially. And so what you do under the umbrella of healthcare in your province can be distinct from other provinces. And Quebec decided that assisted dying healthcare. And they made that distinction very early on. And because of that, they said, well, we don't need federal permission or federal law. It's healthcare and we control healthcare. So they went ahead and legalized assisted dying as early as December 2015. It was legal in Quebec before it was legal in Canada. So obviously some disconnect there, but they had been ahead of us in terms of debating the issues and taking on the new issues. That said, they have a different law than the rest of our country, and we are now working to get those laws meshed. In terms of moving between hospice care and regular care, I actually don't know that it's any better in Quebec. I don't believe that. I think there are many centers in Canada where it is seamless. It is unfortunate that there are some centers where it is truly obstructed. And if you are in a facility that's usually faith-based or perhaps a palliative care facility, they may not allow even an assessment for MAID on the premises. And if that's the case, the patients need to be transferred out. We call those forced transfers in order to be assessed for MAID and in order to require MAID, which is quite cruel and something we're trying to change. I don't know that it's any better or worse in Quebec with regards to that. Quebec does not allow oral MAID. That's not an option in Quebec. And Quebec does not allow nurse practitioners to be involved where they are allowed in the rest of Canada. So they do have some distinctions still. Yeah.
I was going to ask you about that because doctors are not the only people that assess and provide MAID in Canada, except in Quebec. I didn't know that.
Yeah.
Tell us about how you included, I don't know if it's called paraprofessionals or not, but non-MDs to make the assessments and do the provisions.
Yeah, so in terms of assessments and provisions, the only clinicians that can do it are MDs, so it'd have to be medical practitioners or nurse practitioners is the only two. But from the very beginning, it was felt to be within the scope of practice of nurse practitioners. I think in the States, they call them advanced care practice nurses or advanced care nurse practitioners.
New Mexico only, yeah.
In New Mexico. And I wouldn't be surprised if you see that, happen in other states in the States. Hopefully that's true. In New Zealand, they have a new law, of course, came into effect in 2021. They also allow nurse practitioners. So I think they saw that from Canada. That's one of the examples of an international jurisdiction, seeing what's happening elsewhere, taking something that seemed to make sense, even in their own model, and bringing it in. I think that's wonderful. But it is restricted to those two. In the CAMAP community, we recognize the wide diversity of people that need to be involved in doing this care properly. And we welcome into our community social workers, lawyers, pharmacists, nurses, RNs, administrators, policymakers. All of these people are involved in providing the best of care for our patients. But ultimately, the responsibility for the assessment and for the actual administration, because we primarily give the medications, has to be MD or nurse practitioner.
I'm a member of CAMAP. I get a lot from the correspondence that goes on there.
Good.
I wanted to ask you to segue the forced transfer issue to the legislative issue. Forced transfers are pretty horrible when you have to take somebody out of their hospice or who can't.
Or their home,
their
residential home.
That's another question. But I wanted to ask you about the mechanism of the changing of the law. Essentially, we have alluded to the fact that every 2 years, the Parliament looks at the law, evaluates it, and makes changes. So far, all for the better. That's quite normal.
So that's we shouldn't assume that that's a regular activity. In fact, the original law was kind of foisted upon the government to make because of our Supreme Court decision. And in fact, the next change that we had in 2021, that was foisted upon the government because of the decision that we had to remove that one criteria by a Quebec Superior Court decision. So the government's kind of been, held to the task because they had to in both circumstances. The government legislated for themselves. It was in the original law that they had to review the outrolling of assisted dying, to review how it's working, to review what other issues they wanted to discuss, advance requests, mature minors, the issue of mental health. Those were mandated to be reviewed 5 years after the initial rollout. That was supposed to happen in 2020. When COVID hit, everything went to hell, and that review didn't happen. When they did change the law in 2021, they reaffirmed their commitment to review these issues. And to be blunt, it's just not happening. There's no real will. I don't see a big will in our government to open this topic up again anytime soon. But I think, typically what happens in Canada is someone challenges the system. And so on the backs of another patient or family, we may well see continued change. But it's by far not necessarily going to be happening every 2 years. It's a wait and see.
I have the impression that in 2023, there will be mental health cases allowed. There will be, I forgot what I was going to say now, and also the forced transfer issue and mature minors.
So the mental health issue was technically covered in 2021, where they said you've got until 2023 to get ready for it, but it'll automatically happen. So we don't need to revisit legislation. mental health patients will be allowed access to MAID in 2023 unless the government forcibly and actively finds a way to stop it. So that's automatic. The issue of forced transfers is being taken up by advocacy groups and likely will be court challenged, because in Canada we have a universal healthcare system. So if my tax dollars go to pay for the hospital, which they do, you can argue that they can't say, well, we don't provide this care or that care because we don't like it. You can't do that in a universal healthcare system. You're the hospital in town, you've got to do the surgery, you've got to have an emergency room, and you've got to do any covered legal medical care, which includes medical assistance in dying. So there's going to be an advocacy movement, possibly a court challenge to challenge forced transfers. In terms of the other issues of advanced requests and mature minors, the government is mandated to review them. There is a task force that was set up and disbanded with our last election and has not been put together again yet. So I do think that conversation's coming. It's just coming slowly. So I don't know when that will happen. Hopefully in the next year or two.
You work very closely with Death with Dignity Canada. That's been a very good alliance for CAMAP and providers. How does that work?
Yeah, we do. We're good colleagues. So Dying with Dignity Canada is an advocacy group, not dissimilar from Hemlock in that way. They advocate for public access to good end-of-life care, specifically the right to die with dignity and through assisted dying. They've been doing so for 30 years. They're a national organization. We at CAMAP are not an advocacy group specifically for assisted dying. We advocate for our members who are the clinicians that do the work of assisted dying. And we specifically don't advocate for change in law or for aid in dying because we want to be seen as we are clinical experts in the care. So we have an ability to go to government and say, I hear you're thinking of changing the law. Let me tell you what happens at the cold front. This is what I see as a physician. I see patients suffering more because they have a 10-day waiting period. You know, originally our law said patients needed to do all the signatures and get all the permission and go through the eligibility, and then they had to wait 10 days before they could access MAID. And I went and I testified in front of the House of Commons and the Senate to say, I understand you set this up on purpose to be a safety measure, so people had time to think about it. But let me tell you that from a practical point of view, not only is it not saving anybody anything or safeguarding anyone from anything, it's creating much more anxiety in patients and families. They're refusing to take their pain medication because they don't want to take a risk of not being aware or capable 10 days later. It's a tremendous disservice to our patients, causing poor care and poor quality of life and increasing suffering. I recommend you remove that as a safeguard. And as an organization, CAMAP can gather information from all our providers and feed that kind of information back, as long as we're experts and not advocates. So that's something we do. So yeah, sure, we work closely with Dying with Dignity on many things, but we are distinct in our roles. And we do offer sometimes educational events that we co-sponsor, things like that. So very closely involved.
I'm just going to ask one more question before I throw it out to the audience again.
Sure.
But you mentioned two cases, Nevin and Suzanne. In both cases, you did not offer help to them. One died a natural death on palliative care. That was so sad to me. The palliative care doctor did not want to reduce his pain medication, so he had the capacity to ask for help in dying.
Yes.
And in Suzanne's case, I can't remember, but she went doctor shopping after you said she was not eligible, and she got and made provider and assessor to give her aid in dying.
Yeah.
Do you have? I mean, the law's changed since then, so maybe it's helpful. But how did you feel about? I mean, you're very careful about following the law. You don't want to take any chances. You talk about 14 years in prison.
Yeah.
Yeah. What?
Yeah. So those two cases in the book, I think, were great examples of two cases where I did not feel that I was able to tell people that they were eligible, and that I very much wanted to help them, and I felt that I couldn't. Both of them were very early on in the first 6 months of doing this care, and I hope that chapter highlights how careful we are. I don't know anyone doing this work who's looking to push the boundaries and step outside them and be the Morgenthaler or be the Kevorkian. That's not what we have in our clinicians. We are looking to work within the law. We're grateful for the law. We think it allows a formidable step forward. We want to work within the law. But in the first little while, especially, we didn't really know what it meant or how to apply the law, what I could do, what I couldn't do, and who had those answers and who was I supposed to be asking for. So, if you're not sure, you have a choice. Well, I'm not sure I'm going to do it, or I'm not sure I'm not going to do it. And with 14 years of jail hanging over me, I personally felt, I'm not sure, I'm not going to do it until I know. And both of those people went on to have different outcomes. How do I feel? Terrible. I feel like I let Nevin down. I will always regret that I didn't have the courage to get on an airplane and help him. But I also know that I made the right decision at that moment, at that time in my career, at that point in the law. Had I done so, I might have found myself in court and not able to help any other patient ever. And in the end, I think I would have won that court case, because now that I understand the law better, I think I would have been okay to do that. But I didn't know that then. And now, as we have new law and new structures and trying to understand this new law since 2021, it feels a lot like 2016 again. There are new things I don't understand, new things I have yet to figure out about what I'm comfortable with and what I'm not. And as an example, I have colleagues who've been doing this for 5 years, but now that patients can access MAID who aren't near end of life, some of my colleagues have just peeled off and said, I'm not comfortable doing that. I was comfortable helping someone with terminal cancer, but I'm not helping someone with chronic pain. Like that, they're not sure. Their own personal moral tension is plaguing them. They're not sure. So they're going to take a step back. And maybe 4 or 5 years from now, they might step into that. Maybe they'll have learned more. Maybe they'll be more comfortable. But we all have to respect our own boundaries. I'm human. I need to respect my own professional boundaries and my own personal boundaries. And I think that chapter highlights that it's not so simple all the time.
No. I said one more question, but I do have to know, can you briefly summarize the effect on your family? Has anybody been harassed? The kids are out now, but they were teenagers.
Yeah, no, I keep telling you, I live on Vancouver Island. In the MAID circles, we call it Paradise Island. I'd say, without exaggeration, probably 90 to 95% of those on Vancouver Island are extremely supportive of assisted dying and embrace this care. I have been very lucky. I've received a little bit of mail from people quoting me psalms and a little bit of religiosity thrown my way. I've had some things on the internet said about me. I've not had any personal attacks, knock on wood. I've been quite lucky. I do have a colleague who's had the word killer spray painted across his office door here on the island, actually. But we've been pretty lucky. I do have colleagues across the country who have received significant threats. But I would emphasize that they are far and few between. We, as a general rule in Canada, the Canadian public has embraced this care. They are proud that we offer it. They are grateful for it to be available. They are extremely grateful for the few clinicians that do this work. I feel quite supported in this work, and the outliers, will say what they will. I'm not going to change their minds. I will respect their opinion as long as they respect mine and that of my patients. I've been quite lucky.
And you've had hostile families.
I've certainly had hostile families. They've not always been so polite to me face to face, but in other work, sometimes you make a decision as a physician that families aren't happy with, and sometimes they're just upset about something else and they need someone to take it out on. I received a letter not recently about someone who I think I gave pretty good care to, and the surviving spouse is very, very angry with me, and I know that because she's grieving. She needs someone to blame for something that happened. That had nothing to do, and I'll take that letter. I have thicker skin. I'll put it away and I'll try and learn from it. Maybe there was something I could have done better, but what she's angry about is not really me.
So in the Netherlands, there was at one time some consideration of making assisted dying legal for elderly who have passed a certain age but have no debilitating conditions. What's your opinion of this movement?
Yeah, so that's the idea of a completed life. So somebody says, look, my life is over. I've completed my life. I'm ready to go. I don't believe that is legal in the Netherlands at this point. I don't believe that's going to be legal in Canada at any point. I keep my own opinions out of it because it doesn't really matter what's going to be the law. I don't think we're ever going to see that. I think if someone is of a certain state, if they are frail, and we certainly see frail elderly or frail not so elderly, people come in who have a little bit of this and a little bit of that and little heart failure, a little eyesight problem, little deaf, but all together they've been declining over the past year or two, and they've become very, very frail medically. Frailty is a medical diagnosis that can qualify for assisted dying. That's different than someone who just says, I'm 95 with a completed life. I don't see that ever becoming legal in Canada.
Okay. How would you describe the frame of mind of patients at the final appointment? Are some of them happy, relieved, fearful, grateful? And
I'd
how much
say
interaction do you have with the patient before the final appointment?
I have quite a bit of interaction with them. I certainly choreograph the event with them. I check with them usually 48 hours before it's scheduled to make sure they still want me to show up. And we, of course, have to get permission again immediately before we give the medication, unless there's that waiver of final consent. So I have quite a bit. And I also always verify capacity one-on-one with the patient at some time before we start. So I quite like that interaction. It's one of my favorite interactions with patients. Right before we start, I spend 5 to 10 minutes with the patient. Just how was last night? How are you feeling about this? You have any questions? I can go over what'll happen. I find, I'd say 9 times out of 10 or more than that, patients are really very at peace, very relaxed, quite content. It's hard to say eager, but the sentiment that I hear is, I'm ready. I'm ready for this to happen. I'm grateful you're here. Let's get this done. That's what I hear primarily. The families, on the other hand, are the exact opposite. The families need attention. They are beginning their grief. They are quite upset. And that's a different patient. Technically, they're not my patients. That's a different skill set.
What's the psychological impact on MAID providers?
I love that question. Thank you for asking. I addressed that a little bit in the book. We certainly were warned by our colleagues overseas that this is intense and emotional, and you need to take the day off and care for yourself. I don't doubt that. I think those things are generally true. But I have to say that in the qualitative data we're collecting right now amongst my colleagues and publishing, and personally, I would agree, I don't feel badly doing this work. I truly feel like what I'm doing is facilitating someone's final wish, the final wish of a dying person. Be able to offer them what it is that they are desperately seeking has turned out to be profoundly meaningful work. It makes me feel like I've done something good in the world. And I know that the optics of that don't sound good out of context. Oh, I help people in their lives and I feel great. That's not on the surface, that doesn't really capture what I'm saying. But I would just emphasize that the work is very meaningful, and the patients and their families have expressed an overwhelming amount of gratitude for my work. So I feel quite comfortable in what I do. I don't feel like I need to take the day off when I do this. I am always careful to check in. I see many sad situations, sometimes tragic. And of course, I'm human and it affects me, and I might go home sad. But overall, I still know that what I'm doing is what the patient has asked me to do. And I feel good about my work.
Does Canada have any legal requirement about how doctors in hospice disclose their MAID policy, such as posting it on their public website?
Yeah, I don't actually know the answer to that. I think that they don't have to, but I think there's, I think that Dying with Dignity Canada has a campaign called Shine a Light, which actually announces on their own site what the policies are of all those places. So there's been a movement to publicize what those positions are. If there's a unit that is obviously obstructive, that they're trying to shine a light on that, because a lot of places have actually changed their policy in the past 5 years. I don't think it's mandated, though, as far as I know.
Okay. How did COVID affect the requests for help? What about those suffering from long COVID?
Yeah, so that we have yet to see. COVID, for people who were acutely ill and dying, MAID is not really the answer. That what they need is good quality access to good quality palliative care in a fairly urgent situation. There might have been a few people who had enough time to organize MAID, but MAID is not really an emergency event. It's meant to be a process and a procedure that's planned. What COVID did, however, is with our lockdowns, people in long-term care facilities especially were basically locked out of the world. They couldn't have visitors. They couldn't go out to see their family. There was a lot of suffering created by the safety measures, which I think were important, but the side effects of those public health measures, I think, were underestimated. And we did have some people say, look, I'm at end stage cardiac failure. I knew I was going to be applying for MAID in the next little while. I had hoped to get through the summer and call you in the fall, but now I can't go out. My family can't get in. This is existing, not living. I'd like to apply now. So we did have some of that. And some of those patients went ahead, qualified because they would have anyways. So that's sad. That's tragic, but not surprising. And what COVID really did from my point of view, COVID changed the feel of the event itself. These are intimate events where I'm holding the hand of the patient, I'm up close talking to them. Families are in close. When COVID was going on in full force, all of a sudden we're all in masks with PPE and face shields and gowns, and I've got gloves on, and we're not talking to each other close to each other. I'm giving advice out in the patio outside 6 feet away. The feel of the event changed. And I think that's a real loss for such an intimate event. We're trying to find ways around that, but we still have to be careful. This pandemic is not over, my friends.
So in the US, the Alzheimer's Association is a strong opponent of MAID. Is that also true in Canada?
Not true in Canada. I've not actually read their policy recently, but I'm pretty sure that they have. I know the Parkinson's Society of Canada has made a statement saying that they support their membership of people who are interested in exploring MAID. I'm pretty sure the Alzheimer's Society has something similar, and I should know the answer to that, but I don't. I do not think they're forcibly against this. I think they're open. I think they're taking a neutral stance. Is what last time I checked. I'm pretty sure that's where they're at, and I think neutrality is fair.
What are some of the ways physicians judge capacity?
You're asking me how I do my job. Well, I'll be flippant and say that we judge capacity unconsciously all the time, every time we interact with a patient. If I'm going to write a prescription for blood pressure medication, I need to know the patient knows what I think the problem is, that they understand what the problem is, why I think this is a good medication, what the pros and cons of taking that medication are, and that I think they're going to fill the prescription and take it. All of those are elements of capacity. So without even thinking about it, physicians constantly assess capacity in patients. Okay, flippant, but true. In MAID, obviously, we want the bar to be fairly high. How do I do that? I actually am not fond of objective testing and formal testing. I sit and talk with my patients. It takes me a lot longer, but I sit and talk. So tell me, why are you calling me? What's wrong? If the patient has no idea where they are, what's wrong with them, who I am, or why I'm talking to them, they don't have capacity. Capacity is about understanding your illness. It's understanding your treatment options, the pros and cons of them. It's about appreciating your decision-making in the context of you and your whole family. So if you made this decision, who would be affected by that? And then articulating a request to die. If those elements are present, the patient has capacity. If those elements are not present, the patient doesn't have capacity. I determine that by speaking to my patient as many times as I need to convince myself that that is true. And if I'm not sure, I reach out to colleagues to get their opinions as well. I don't know if that answered the question, but that's the truth of the matter.
Stefanie, can I read you a question that somebody sent us? It's from a person who says that I have a family member who is an assessing physician for MAID in Canada. He
Yes.
told me that if a patient is depressed, he cannot clear them for MAID. Could you comment on that?
Yeah, I think it's an important nuance. So if a patient is having an acute depression, they have active depression. Depression is going on in them to the point that they meet the clinical criteria. They are depressed. That by definition means their mental state is affected by their diagnosis. They probably need medication, therapy, treatment, support, and we can treat depression. If someone is in an active stage and actively depressed, clinically depressed, they don't have the capacity to request this care. However, there are many people who have depression, who have had depression, who have stable managed depression over X many years. They have bouts when it's worse and bouts when it's stable. A person with depression doesn't necessarily not have capacity. It's my job to determine whether their capacity to make the request for MAID is present or not. I think if they have an active clinical depression, they probably don't have capacity. However, I can treat that, or their physician can treat that. And 3 months, 6 months, 9 months later, if they're still saying, I want to end my life because of, my slow growing ovarian cancer, as long as their depression is stable and being cared for, and they're not in an active state of depression, they can still qualify for MAID. So I think it's important to draw the distinction.
Another question is, what's your experience been when a patient's family really disagrees with what the patient's wanting?
There's a great chapter in the book about that. So I think what I'll just say is we are really clear in Canada what the law is and what it allows. And again, in Canada, this is a patient's right Patient-centered care comes from patient right issue constitutionally. So I am very eager to facilitate respectful listening amongst all the warring parties. I always encourage the patient to be the one to explain what they're asking for and why, so that their loved one can hear it from them. I always encourage the loved one to express what their concerns are and why, and in a way that's respectful. No one's shouting at each other. And I'll sometimes bring in a professional counselor to do that if I'm feeling out of my league. I think once that kind of conversation has happened and people have had a chance to express themselves, a lot of closure can happen. A lot of understanding can happen. People may not agree, but they may agree to say, look, I disagree. I could never do that. I think you're making a mistake, but I will respectfully step back and you will make whatever decision you want. We often get to that place. But ultimately, in the end, it doesn't matter what anyone else thinks or says or believes. It is irrelevant under our law. A patient has a right to ask for this if they meet eligibility criteria. I am allowed to help them regardless of what their loved one says. And I never like to say it that way up front, but that's the truth. They can make my life miserable and argue with me afterwards for years and make complaints at the college and, threaten my license. Ultimately, I'm going to win that argument because I know what the law says. So I try to, gently facilitate through that dilemma.
Can I ask a question for myself, Stefanie? It seems like the biggest group of people that are left out of the current legislation in California and other states here in the US are people with dementia.
Yes.
And we're talking huge numbers of people who are left out. And I know you've talked a little bit about working with some dementia patients in the past. And I'm wondering, could you describe for this group just a little bit more about how you work with a dementia patient and at what point you sort of feel comfortable allowing them to take advantage of the law in Canada?
Yeah, so just very briefly, because it can be a complicated topic. So two things. Number one, so basically what I like to do in the way that we work, it's a model that we call 10 minutes to midnight. It means that I would meet with a patient relatively early in their disease. They tend to be diagnosed and have symptoms. And then at some point they say, oh, this is not going well. They call me up and say, hey, I'm interested in an assisted death at some point in the future. I meet them, I get to know them while they're still able to express what their views are, their lifelong views, their values, what they're worried about. I get to know them, I document that. I then see them on a semi-regular basis, maybe every 6 months. As they decline through their illness, I document that. I document objectively what I'm seeing, what's changing, what they can do, what they can't do, their loss of function. They can't use the telephone anymore. They can't use the remote control anymore. They can't dress themselves anymore. As they go through their illness, I see them more frequently, every 3 months, maybe once a month. At some point, as they're getting around close to midnight, I'm going to say to them, Bob, I've known you now for 18 months. You've made yourself very clear to me. I am concerned that 3 months from now, you may not have the capacity to make this decision anymore. I'm concerned you're getting to that place. Now, the truth is many dementia patients, as they get sick, will stop caring. They'll stop being worried about it. They'll stop suffering because they're losing their insight into what's happening and their judgment of what's coming. And if they say to me, hey, no worries, Stefanie, I'll see you in a year. I'm doing great. That guy's not going to qualify. He's not going to speak up. He's not going to have MAID. But I see patients, and it's part of my job to say, you told me a year ago that if this and this and this, that would really be upsetting to you. Now you're telling me you're feeling great, but from what I see, you can't do this, you can't do this, and you can't do this. How are you feeling about that? And then if they say, hey, I'm fine, we don't do anything. But if they say, oh, you're right, I don't even, I didn't even remember I had grandchildren. They're at that point where they realize what's happening. Then they might say to me, I'm done. I don't want to go further. I can't let myself go down that path. I've seen it in my mother. I've seen it in my father. I'm ready. I'd rather die now. At that point, at 10 minutes to midnight, I can help them. They're 18. They've made a request. They're eligible for Canadian health care. They have a grievous and irremediable condition, and they still have capacity. That person can then say, please come over on Thursday at 3 and help me do this. And I can help that patient. But it doesn't happen with all dementia patients because, as I said, some people stop asking. So that's really how we do it. It's a model called 10 minutes to midnight. There's actually a guidance paper that's publicly available on how that works on the CAMAP website. And if you want to hear more about me talking about it a little bit slower than I'm talking today, there is an excellent radio documentary that I made about this with the widow a patient who I helped early on. His name was Gail Garlock. It's Gail, Gayle, Gail Garlock, Garlock. And if you Google Gail Garlock CBC, which is the Canadian Broadcasting Corporation, there's a radio documentary. It's about 30 minutes long. And myself and his wife talk about our experience going through this process and how it worked for Gail. So I would recommend that as a listening homework for anyone who wants to know more about it.
Somebody wanted clarification whether you must be a resident or a citizen of Canada to access MAID. Which is it?
So it's actually neither. So we've actually spent some time deciphering what it exactly is. So we weren't sure at the beginning, but I'm afraid you're all SOL. So the answer is you need to be eligible for Canadian healthcare. So yes, of course, if you're a Canadian citizen or you're a landed immigrant or a refugee with status, a guy who lives under the bridge who lost his card proving he's got eligibility, but he's still eligible. Anyone who's eligible for Canadian healthcare may apply. In fact, Canadians living abroad, they come home and reapply for their healthcare because they're Canadian and they are eligible for care. You might have lived in Singapore for 20 years, but if you're a Canadian citizen, you can come home and be eligible. Who can't is someone who's not eligible. If you're not a Canadian citizen, you live in the States, you cannot come up and pay privately for this. You're not eligible for Canadian healthcare. So that's the problem.
I remember seeing a question on there, Janet, about can you only buy the book on Amazon?
Certainly not. You can get the book anywhere, everywhere online. Your favorite stores, Barnes and Noble, Amazon, Indigo in Canada. Independent bookstores will be carrying it on their shelves as of March 29th. Please do me a favor, walk into your favorite bookstore, ask them for it. If they don't have it in stock, ask them to bring it in. There's no reason why they shouldn't be stocked up. It's ready and raring to go. There's an audio book available. There's a digital version available for your Kindle or whatever that is called these days. And there's print book in both softcover and hard. I think it's only hardcover in the States right now. Yeah, it's available.
That is published by Scribner's, a very reputable publisher of American literature and textbooks.
Yeah, especially books about death and dying. I feel very fortunate to be in Scribner. I don't mean to sound arrogant, but this is not. And I love self-published books. This is not that. This is not a small endeavor. This is a large endeavor by a large publishing house in the U.S. Who bought this product and is hoping to distribute it and sell it widely. We've actually sold rights to other countries as well. I'm very hopeful that this will become well read. Yeah, this is Assisted Dying, a doctor's story of empowering patients at the end of life. And I'm very proud of it, so I'm obnoxious enough to say that out loud.
We're just anxious to read it, and I'm sure all of our members, or almost all of them, will have a copy in their hands pretty soon.
I hope so.
And anything like this is wonderful because it just simply widens the number of people who are aware of this issue and how it works in other countries and how it could work in this country. And I think that's the big issue that we struggle with, is how to raise consciousness in this country to get past all the fear mongering that goes around this issue.
In fact, the truth is, I purposely don't position myself. I'm not an advocate. I mean, obviously I'm biased and I think it's a good thing to have assisted dying. This book is not about advocating for MAID. The purpose of this book is to contribute to the conversation around death and dying, and not so much about death and dying, but to me, the purpose of this book is to encourage people to think about what's important to them, what brings meaning to them, what brings joy and meaning to their lives. Because I almost don't care whether you choose an assisted death or not is irrelevant to me. It's not my business. What I want you to do is think about what's important to you and then know what tools are available or not available where you live. I mean, that's the discussion I want to happen. I want this book to be widely read because I want people to have that conversation that they're scared to have, that we all delay and don't have until someone's in the emergency room. We need to have those discussions earlier. We need to talk to our loved ones about what's important to us. Whether assisted dying might be a tool you would consider, okay, that's an interesting conversation too. But I think that what you're saying is I want to contribute to that conversation. And what really propelled me to write this book is not even that, although that's important. What really is that I found myself in these extraordinarily new circumstances, meeting extraordinary people, asking things of me that I'd never considered before. And I witnessed these just almost indescribable events over and over again. I felt the need to explain to people what I do, what it is, because there's so much misinformation out there. People talk about assisted dying. They have no idea what they're talking about. This book describes this is assisted dying. This is what it's about. This is what it looks like when you talk to a patient and hear what they say to me. And I bring you into the room and tell you what it's like to give that medication and how it feels to me to do that work and how it affects me and my family and my personal life and my work life. This is the coal face. That's why I wanted to write this book, to dispel those myths and tell people what it really truly is. And from the perspective of someone who provides the care, which I think is a unique perspective out there. I don't think we have that out there yet. So that's where I think I can contribute.
Well, thank you so much for writing the book, and thank you so much for spending your time with us this afternoon, Stefanie. I hope we've answered everybody's questions who is in our audience. If we haven't, we've tried to. And so again, thank you so much. Faye, did you want to have anything else you wanted to add, or?
I just want to thank her. It's so wonderful to see her again. Hope to see you at the World Conference in Toronto.
Yeah, I hope to be there.
Okay.
The only thing I'll say is if people are looking to contact me, if people have questions, it's a little busy this next 1 or 2 weeks coming up with the book launch, but I'm happy to hear from people. You guys are one of my favorite organizations. You've always treated me well, and I think you do great work. The best way to get information about me or my book or to find me is through my new website, which is stephaniegreen.com. Easy to remember. You just have to spell my name properly, which has an F in it, like Frank. There's no PH. stephaniegreen.com. You get all the information you need and how to contact me if you want to.
Okay, thank you so much, Stefanie, again, and thank the members of our audience. Thanks for coming.